progress to both providing competition but not turning over the whole apple cart, to stay with the farm analogies. So I'll just say one thing. And with, Brent, you and I have agreed to disagree on this. The hospitals with Medicaid expansion are going to clear, from the reports we have, $1.2 billion a year. We are not here to preserve your bottom line. We don't want our hospitals going out of business, but I believe you can do that while shifting some of these expensive, those of you that don't know, hospitals have facility fees that they affix to any services that they provide in hospitals, which innately makes the cost of getting some of these procedures done in the hospital higher. And so this is a great bill that I'm really excited to support and endorse. And after those comments, I'm going to move to report.
All right, second motion. Second.
Second.
All right, further discussion on it. I'll offer a few thoughts here. One of the things is that the reimbursement system that operates in the United States, it's a national issue, it's not a local issue. It doesn't make a whole lot of sense. What we have is, in effect, charges that are substantially higher than any reimbursement rate that's provided by commercial or private or public insurers. But what we also have is situations where there are certain services that are extraordinarily profitable. There are other services on which hospitals and other types of facilities lose substantial amounts of money. And one of the things that is, I think, critical here is that we not provide an imbalance that basically sends the message that we want you to provide the services on which you lose money, but we want somebody else to be able to provide the service on which large amounts of money are made. And I can tell you that every conversation that I have with people in the field, when they talk about the services that are highly profitable, it's two. Surgery, particularly outpatient surgery, and diagnostic imaging. And I think if we are going forward with something that is going to undermine the financial situations as it relates to those two services of certain providers there, it has the potential for substantial negative effects on the community. And so therefore I will be voting against the amendment, the proposal to recommend reporting of this. All right, any further discussion? All right, all in favor of the motion say aye.
Aye.
All opposed, no?
No.
No, and Senator Sassel, no, so it's a 3-3 split on the vote that is there. There's one other final bill that we have. He gave a little direction as to how we're supposed to vote here, so. That's right. All right.
Where were you for the earlier bill?
The other bill that we have is Senate Bill 279. It's fairly simple and technical. What it would do is would make clear that in making decisions on certificates of public need, the commissioner would not be limited to the primary service area of where the facility is, but to look at the total number of patients that are using that service, regardless of whether they live immediately near the hospital or other type of facility, or whether they live, several miles away, and in some cases even in another state, etc. So this would just make clear that the commissioner has the ability to take into account, the utilization of those services in the total for the total facilities that's there. Any questions or anyone has on that? Yes.
Let me ask why, right? Because I read it and I got what you said, but I don't know the why. In other words, why residents instead of people living in? And are we trying to restrict the ability for the issuance of the new certificate, or in other words, what's the why?
The why? Yes. Okay. Go ahead.
I can speak to this fairly succinctly. If you look at Chesapeake, which borders the North Carolina line, okay, we had a COPN request in for, I don't know if it was Hart or something like that. The commissioner could not take into account the residents of northeastern North Carolina who utilize all of the Hampton Roads facilities, hospitals, etc. So he was actually prohibited from counting them as people who needed, that type of facility. So your bill fixes that.
Right. facilities that have certain utilization levels, and at some point, you may get a high enough utilization level that there's a reason to move forward with expansion there. But if it's if the patients that you're counting are only those that are in the planning district in which the facility is located, that means that you end up with the type of situation that Senator Crossgrove was talking about there, that they're not eligible for an expansion because a lot of the patients who are sort of generating the need for that expansion don't live in the planning district or even in the state in that case.
Mr. Chairman, that is helpful, that explains the why. But let me ask you the opposite question. What happens in Maryland where they have basically the lack of COPN, although they have other items that interfere with it, and you have a lot of facilities lined up in Northern Virginia? Are you gonna take into account all the facilities that are lining up on the Maryland border now and deny more COPNs in Virginia, because you do get to count the residents, but you also get to count the access in that area? Does it count both or just the residents?
Well, this would be the population, the people who would be served by it. So if, in essence, there were residents, and the example you gave of Northern Virginians who go to Maryland or the District of Columbia or some other jurisdiction for services, if there were the ability to be able to say that some of those would come back, that's certainly something that would be taken into consideration and review the applications.
Mr. Chairman, your bill is specifically tailored to people.
Right.
And just, it doesn't talk about other facilities, it just says instead of the residents, it's the people in
Right.
the area. So it's just people.
Right.
Mr. Chairman, I agree with John, he's right, but they also says in the area to be served. And so my question, I guess, which is under line 37, I guess you boil it down, if you have a hospital locates right on the border of Maryland, are you going to consider that facility as a reason not to put in one in Virginia because of anything in this bill? Or is it only going to say the citizens in the broader area?
No, the answer to your question basically is no, because I reviewed a lot of these applications in Northern Virginia for over 30 years, and I don't recall any situation where where an application was denied because patients were going outside the area.
And this will change that.
So that certainly has the potential to give more flexibility to the commissioner and to have the decision based upon realistic service areas. Any further questions? All right. Motion and second to report. Any further discussion? All in favor say aye.
Aye.
Aye. And my two proxies both vote aye, even if they didn't agree on anything else, so. There's nothing further for the subcommittee, so we will deal with Senator Lucas's bill on Thursday in full committee without having a recommendation. The others we have recommendations.